We've been talking about CAR T-cell therapy for a number of years now. How has this treatment revolutionized care for patients?
Absolutely. So the biggest benefit of CAR T therapy, I think, is how well it works. So I'll predominantly focus on multiple myeloma, but of course there are CAR T therapies that are approved for different kinds of lymphoma and B-cell leukemia as well. But in brief, CAR T therapy, we train the immune system to fight back against the myeloma, against the cancer that's there. And it's phenomenal because it's the only living drug we have really in our toolbox. Everything else is dependent on the dose, right? As soon as the drug is out of your system, it stops working. CAR T cells don't work that way. They can live and expand and proliferate to get rid of the threat within. And at least in myeloma, for example, CAR T therapies regularly have response rates, meaning complete response rates, how quickly they knock all the myeloma parameters down to zero, basically in the 70, 80, 90% range. Many patients achieve measurable residual disease or MRD negativity, meaning by all the best tools available in 2024, no sign of the myeloma anywhere. That doesn't mean cure, to be fair, but that's wonderful. With other conventional therapies, to have one drug with a one infusion have that big of an impact on the myeloma is phenomenal. The other benefit of CAR T therapy is that it is a one-time infusion. Doesn't mean that patients can get one-time CAR T and never have to see a cancer doctor again, because again, at least in myeloma, I don't consider CAR T to be uniformly curative for patients. However, if you look at the studies, and there have been two randomized studies in myeloma of CAR T therapy versus standard therapies. One was a KarMMa-3 trial with a drug called ide-cel, a CAR T drug also known as Abecma. And the other one was CARTITUDE-4, which was a study of a cilta-cel versus standard treatment. Cilta-cel is a kind of CAR T also known as CARVYKTI. Both studies saw improvements, dramatic improvements in the response rate, how many patients had the myeloma numbers come down, but also durations of response and progression-free survival, how long patients were alive and disease-free for. Literally just a month ago, we found out officially that the cilta-cel trial in the CARTITUDE-4 study, CAR T actually prolonged overall survival compared to standard therapies, which is what patients are looking for. But for me, what I love about CAR T the most is not just that you're in remission for longer, or with cilta-cel, you live longer, but that you live better. Both studies, and I'm very happy to see this incorporated what we call patient-reported outcomes, which is an area of research of mine. Patient-reported outcomes are, as you can imagine, outcomes that are reported by the patient, not the blood test for the myeloma, but how are patients feeling in terms of their quality of life, in terms of their fatigue, in terms of their pain. And in both studies, off the charts. CAR T does way better and way faster in terms of improving quality of life than standard treatments, to the point where the studies, for example, often for both of them, if I recall correctly, the first time point where they looked and compared the two arms was 3 months after CAR T. And already by then, night and day difference. The patients who got CAR T, the first month a little bit rocky, but after the first month or two, they're doing better because they're not on myeloma treatments continuously. They're still getting blood work checked and so forth, but they're not on treatment. It's a one-time infusion and monitoring thereafter. And I love that about it. And I think that explains a lot of the quality of life benefits that we see. For my other patients with myeloma outside of CAR T, there is never a scenario where they're observed. The vast majority of patients, because myeloma is considered incurable, we keep them on some form of maintenance treatment. And those come with side effects. Those come with financial toxicity. That's the word we use for high out-of-pocket costs. They come with what I would call time toxicity. That's time spent on the phone, coordinating shipments, or coming in for this infusion or that infusion. CAR T has much less of that. And I think that's phenomenal. So I would say that it's revolutionized the field, not just scientifically from the things that you'd expect a researcher to care the most about, for how long, how deep are the remissions and how durable are the remissions, but also for the things that I care about, the art of oncology is how our patients are living. And that's why I think CAR T is revolutionary.
Dr. Banerjee, would you walk us through the currently approved CAR T-cell therapies for myeloma and share how these treatments work to combat myeloma?
Absolutely so. So there's two FDA-approved CAR T therapies right now for multiple myeloma. One is ide-cel, also known as Abecma. One is cilta-cel, also known as CARVYKTI. The mechanics of them are pretty similar. Both involve T cells being collected from the patient and then turned into CAR T cells, cancer-fighting cells in a lab, then put back into the patient after a small dose of what we call lymphodepleting chemotherapy that creates a void and makes room for the T cells. And then the T cells come in and are able to activate and proliferate and respond and kill off the myeloma. In terms of, the two drugs, the differences between them, we might come back to that a bit in terms of just how they're approved. Cilta-cel is currently approved as early as first relapse, so second line treatment onwards in myeloma for patients who have disease that is refractory to lenalidomide or a similar class of drugs. So lenalidomide is Revlimid. So if someone's been on Revlimid and it stopped working, they could technically go to cilta-cel, which is Carvykti, as soon as second line. Ide-cel or Abecma is approved for third line treatment, meaning at least two prior relapses or two types of therapy that were stopped unexpectedly because of not working or toxicities or so forth. And those patients would have had to have received both an IMiD like Revlimid, which is lenalidomide, a proteasome inhibitor, which is like Velcade or bortezomib, and a CD38 directed monoclonal antibody like daratumumab, which is also called Darzalex or Darzalex Faspro.